Hey everyone, myself Dr. Shravya, Senior Resident in Department of Radiodiagnosis at AIMS Hyderabad. Today I'll discuss an interesting case. A 25-year-old G2E1L1A0 female came for regular antenatal checkup. The patient had conceived naturally and she had no significant complaints. The case was referred to us from Department of OBGYN. On ultrasonography, the placenta was completely covering the internal os. With heterogeneous appearance with multiple interplacental lacunae giving it a Swiss cheese appearance. There was loss of retroplacental clear space and thinning of the myometrium. Therefore, a diagnosis of placenta previa with adherent placenta was given. Further, on MRI, we could appreciate the placenta previa and there was abnormal bulge in the uterine contour involving the right lateral anterior lower uterine segment with gross thinning of the myometrium. Therefore, the final diagnosis was placenta previa with morbidly adherent placenta, likely placenta ingrata. These findings were confirmed intra by the OBG department. So coming to our discussion, morbidly adherent placenta refers to the range of pathologic adherence of the placenta. It is of three types: accreta, increta, and percreta. Accreta is when the placenta adheres to the myometrium without any invasion into the muscle, whereas increta is when the placenta invades into the myometrium, and percreta is when the placenta invades the full thickness of the uterine wall and possibly the other pelvic structures, most frequently the bladder. The risk factors of adherent placenta are previous C-section, placenta previa, previous hysterotomy or myomectomy, or any history of previous DNC. On ultrasonography, adherent placenta usually present with placenta previa. They are placental lacunae with turbulent flow. There may be irregular bladder wall with extensive associated vascularity. There may be loss of retroplacental clear space, and there will be reduced myometrial thickness that is less than 1 mm or loss of visualization of myometry. Coming to the MRI appearance of adherent placenta, MRI is usually indicated when the placenta is posterior or lateral in position. Here is a inside-out approach for placenta previa, where we start from the placenta and we gradually go out and see further any extrauterine invasion. So starting with the placenta, in placenta we see dark interplacental bands. There may be heterogeneous appearance of the placenta. There may be placental bulge, or there may be lumpy contour of the placenta with rounded edges, and there is abnormal or disorganized placental vascularity. Then coming to the placental myometrial interface, there is thinning or loss of retroplacental T2 dark zone. In myometrium, there may be myometrial thinning or focal disruption of the myometrium. And coming to the extrauterine aspect, there may be bladder or adjacent structure invasion, or there may be focal exophytic mass sign. The last two will be usually seen in the placenta percreta. This is a coronal T2 weighted image where the placenta shows moderate heterogeneous signal intensity with abnormal dark interplacental bands with disorganized subplacental hypervascularity. This is a coronal fiesta image showing right lateral placental bulge into the myometrium, and there is a lumpy contour and rounded edge of the placenta. And this is a coronal T2 weighted single shot fast spin echo of a twin pregnancy showing focal interruption of the myometrium at midline, and there is left lateral placental bulge with marked thinning of the myometrium. This is a coronal T2 weighted image showing bladder invasion by the placenta, and we can visualize the placental tissue beyond the uterus. And this is a right parametrial invasion by the placental tissue, and here we can see that the signal intensity is similar in the extrauterine placental tissue as well as the intrauterine placental tissue. Both these cases are of placenta percreta. These are my references, and thank you.